The main thing of it is that it is non-invasive measurement, so it does not imply exposure to radiation. It does not use invasive measurements. It does not require hospitalization of the patient, and it is done entirely with transthoracic echocardiography. You have to dispose of a good quality echo scanner with special settings to do this, and as a ratio, CFR or coronary flow reserve is measured as the ratio between maximal flow at a coronary artery, and this is related to the baseline flow at the coronary artery. So the ratio of these two values is the CFR measurement. If I should describe a main limitation, maybe it is the fact that it describes the overall atherosclerotic burden of the coronary arteries. So as a stand-alone technique, it is difficult with this method to distinguish between epicardial artery stenosis and microvascular dysfunction of the coronary arteries. But there are many clinical settings in which we know that a certain patient has, for example, an epicardial coronary artery stenosis, and in this setting we could use a CFR measurement to assess the significance of this stenosis and also for follow-up of this patient after stenting. And on the contrary, if we know that a patient has chest pain and does not have significant artery stenosis, then assessing CFR and finding low CFR measurements, we could say that this patient has a microvascular dysfunction of his coronary arteries. There are two major ways of invasive measurement. These are the CFR, which uses the same principle as the non-invasive CFR measurement and is the ratio of maximal hyperemic flow to the baseline flow. And there is also the FFR measurement. I could say that there is a very good correlation between non-invasive and invasive CFR measurement, considering all the limitations of one and the other method of measurement, mainly invasiveness and radiation exposure and the need for hospitalization during an invasive coronary flow reserve measurement. This is also one of the limitations of non-invasive CFR measurement, because it is a method inquiring a time which should be dedicated to learn it, and this should better be done in a center with experienced operator, and there is also a steep learning curve. So if a physician would like to do this method, to apply it to his patient, he has or she has to devote some of his time to learn how to do it in order to do it in the right way.
Okay. And finally, what are the clinical implications of this technique?
So there are two main topics where non-invasive CFR could be of use. One of them is to assess patients with epicardial coronary artery stenosis. These patients could have, for example, a significant coronary artery stenosis, and this could be assessed with very good sensitivity and specificity with CFR measurement. These patients could have also an intermediate coronary artery stenosis, and in this way we could measure if the clinical significance of this coronary artery stenosis is high or not using a non-invasive CFR measurement. And also patients who have been stented may become suitable applicants of this technique, because CFR measurement in this setting could show if there is restenosis in the coronary artery that has been intervened, and it is a very useful method for a follow-up of these patients, because it is non-invasive and could be done as often as you want to. The other main application is in patients with microvascular coronary artery disease. There are many such patients. Maybe you know that at least 20% of patients who have chest pain and are referred to coronary angiography, they have epicardial normal coronary arteries. But still, at least 75% of these patients have some form of dysfunction of their arteries. This is mainly endothelial dysfunction and microvascular dysfunction. These patients are a good subset to be evaluated with CFR, and then to follow what is going on in their microvascular system with, for example, some therapeutic applications.